now, we had 1 month of elective where we could choose our specialty, and I very enthusiastically chose neurology as my specialty and regretted it ever after, because I was terrorized by Dr. P.M. Dalal, who was our boss then, completely terrorized by him. Luckily, Dr.A.B.Shah was there as a salvaging person. I could, otherwise it was a bad time for all of us who were there. But taskmasters like Dr. P.M. Dalal and teachers like Dr. Arun Shah have made our tenure in neurology very, very worthwhile, and I really remember those times, so thanks a lot for that. Today, of course, Dr. A.B.Shah is well known to all of you, and if I have to refer any difficult neurology case to somebody, I think first of Dr. A.B.Shah, because I think he's a brilliant clinician and a very, very conservative and logical theoretician, and that is something that I admire in him a lot. And neurology, as you all know, is not only very challenging clinically, but also can be difficult therapeutically for the patient. And in that, I have seen excellent results for patients. Our first subject that we are going to discuss is strokes or cerebrovascular disease. The current interest in strokes is because of the possibility of thrombolytic therapy. Just as we have thrombolytic therapy for myocardial infarcts, which is popular since several decades, we have thrombolytic therapy which is becoming popular in strokes. So, for the family physician, this is very important, because it is you who will recognize a stroke and decide whether to send this patient for thrombolytic therapy immediately. So, sir, a word about that. When should the family physician send a patient for thrombolytic therapy?
Yeah, I think I must first thank for inviting me. Yeah, Sandarth Medical Association, of course, particularly, and the organizers of this symposium for inviting me to participate in the exciting way of taking lectures. I think I was there in the audience for almost 30 minutes, and it was one of the best sessions I have attended, I think, and clears your doubts very well. So hopefully, of course, I must say that these questions of much more difficult to start as producing than what I have. Right. We had purposely thought that we should start with stroke, because this is where good cooperation from family physicians is required to improve the therapy of our stroke patients and improve the quality of life of the stroke patients. I mean, say about a decade ago, we could do much towards stroke, right? That's why the nihilistic attitude we developed. That person with is in hospital at home, the caregiver is only supportive care. So why do I send the patient to the hospital? And the usual family physician concept was to record BP, do some basic workup, and wait for the neurologist to receive next day or something like that. I think both types of stroke, as you know, there are two kinds of stroke we deal with, the hemorrhagic and ischemic. Almost about 80% of strokes are ischemic and about 20% are hemorrhagic. And first 3 hours, or say 3 to 6 hours, are very vital in both kinds of stroke from the therapeutic point of view. And hence, the first thing one has to do is remember a cartoon of FAST. The FAST word is face, arm, speech, and time. So you look at the face, you find a drooping of the face. You do an outstretched arm test, and if you find the hand is drooping, and whether the speech is slurred, think that you might have suffered a stroke. And then time is the right factor. Because every minute or every second you are resting, some billions of neurons and pathways are getting back. So you have a vital time period wherein the brain is not functioning, but is still salvageable. If you reperfuse that brain area, like perfuse myocardium and salvageable, if you reperfuse the brain area, probably the brain neurons will remain vital, and probably will reduce the amount of deficit the person is going through. And this is proved well now. The thrombolytic therapy for acute stroke was first approved in US FDA and later on in all the countries, including Europe and India, way back in about 1996. So now we are in 14 years. And the sorry state of affairs is that the recently worked out statistics in India, it appears that less than 0.01% of patients receive thrombolytic therapy in our country. So this is the state of affairs, and I think we are missing opportunities day in, day out. So, last time I gave a talk on this subject, and at the end of the lecture, some physician came back to me and asked me, family physician, yes, doctor, we listened to your talk very well and everything, but supposing I'm called to see a patient of stroke, is developed right hand weakness, speech disturbance, what do I go and offer him at home? And I told him, don't go to his house. Call him to a center where imaging is available. You reach there and coordinate his therapy, and that is the best way to deal with acute stroke, rather than waiting that, I'll come and I'll finish my clinic and say I'll come after 2 hours. That's the wrong strategy to take, and this is the message I want to give to start with in relation to stroke.
So when the patient calls you from home, my father's right hand is not lifting up, etc., your immediate response has to be reach a place where there is an imaging center. It can be in a hospital, preferably where there is also a stroke unit. And that's the best thing that you can do for the stroke patient, so that the time window, which is only 3 hours, can be satisfied in some cases. Which strokes are thrombolized? Within the ischemic strokes, which strokes are thrombolized? Are all the road strokes, midcircularity and midcircularity, all are thrombolized?
Yeah. I think nowadays, after about 14 years the drug being available to us, 3 things one has to remember. Because we are all familiar with cardiac thrombolysis and thrombolysis in the stroke is very, very different. In relation to heart, you have ECGs, atrial elevation, acuity, all the criteria which are available bedside and bedside. In relation to stroke, this is not possible, because these things you should not do treatment for the other differential diagnosis, like stroke mimic or hemorrhagic stroke is not thrombolysis. So you need to have imaging. So that's a question which has been asked to me. How do you differentiate hemorrhage and ischemic? By and large, bedside, nobody can be certain that the stroke person has got is hemorrhagic or ischemic. So imaging before thrombolytic therapy is a must. That is first answer I would like to give. And of course, thrombolytic therapy can be offered to all the patients who come to you with a focal deficit and case of presumed ischemic etiology. That means you have a CT scan which has ruled out hemorrhage, and then you have at least basic workup which is ruled out stroke mimic, that is checking sugar. Because hypoglycemia is one of the commonest stroke mimic. So if you have sugar less than 50 or 60, he is not a candidate for thrombolytic therapy. Or if your CT scan shows something else, as already old mature infarct, or a subtherial hematoma, or a neoplasm which is responsible for his deficit, or a hematoma, then he is not a candidate for stroke. In relation to ischemic stroke, only the point to be mentioned is that person should have a measurable deficit. That means a person has, say, mild sensory symptoms on one side, nothing else. Then his stroke is so mild that it is not worth taking the risk of thrombolytic therapy. What is the risk involved in thrombolytic therapy in relation to stroke? Development of brain hemorrhage. And this risk goes to almost 10 times if you don't thrombolize. So risk is significant. So hence, in a minor stroke or a stroke person who has very mild deficit, non-measurable, or a person who comes to you and is rapidly improving. For example, at home, he got up, he had a right hand weakness, power was 0. And by the time he comes to you or you go to his house and you find the power is almost grade 4, then he is again not a candidate for stroke. Apart from this, there is no other contraindication. Of course, there are many other contraindications like a bleeding diabetes, history of seizure, hypoglycemia, very high sugar, which of course there are strict protocol we follow. There are about 14 exclusion criteria which have to be satisfied before we thrombolize the patient.